Hey, good morning and welcome to UroNurse. I'm your host, Vic Senese. Welcome to the show. We come to you every Saturday on all of these factors, every Saturday at 9 a.m. Central Time from YouTube, LinkedIn, Facebook, X. I think I caught them all. If you're not subscribed yet or liked us on Facebook and YouTube, go ahead and do that. We're burning it up right now with all our new people joining, so we love it. Hey, if this is your first time joining us, be sure to check out our website at UroNurse.com, the best place to go to check out more about our show. Also, to watch our other podcasts. There's links to all four of my new podcasts going now. Also, best place to find all of our past 128 past episodes. They're all available. Just go to the website. Now, some of you like to listen to us in your car, I hear. Great. Glad to have you on board. You can get our audio podcasts on any of your favorite podcasting platforms like YouTube, Spotify, Amazon, or Apple by going to our UroNurse Plus area and clicking on it. Every show goes to the podcast, the audio podcast, about an hour after this show airs. So check it out. It'll come to your box if you subscribe automatically. So this week, got a great show for you. I'm going to be talking about ureteral stents. Did a little survey. Glad to have people who filled that out for me. So we're going to get that going. But first, let's go ahead and bring in our experts. Our experts are here today, and that would be Lori and I. Hey, Lori, welcome to the show.
Good morning. Hi, my name is Lori Atkinson. I'm a certified urology registered nurse. I have been in urology for about 26 years now, and I currently work for a large urology group in Geneva and Winfield, Illinois. Glad to be here. Glad to be back.
Yeah, glad to have you back. Of course, during the holidays, a lot of us were doing other things, including myself, but I'm always here for the show. Vic Senese, you know me. I've been around in urology for the past 40 years, and I'm going to be the guest speaker for today. So I hope you enjoy the show. I'm glad to have Lori on board to handle some of these questions that may come in, or even just to ask a few questions herself. So I'm ready to get going with the show. Let's go ahead and bring in our slides. There we go. So ureteral stents, I call it Survey Says because I did a survey. You know, one of the fun things that I've found out having UroNurse is the ability to do other things. Now, I've never been a big research person, but gosh, I'm starting to really enjoy some of these surveys I've done. They're simple. I send them out. They're anonymous. You guys don't have to put your names or anything. And hey, thanks for those of you that filled them out because it gives us a little idea of what's going on out there besides our own practices. So first thing I wanted to look at is who's taking and filling these out for me. So I asked what your role was, and we could see that by and far most of the our nurses, which is what I kind of expected. A lot of nurse practitioners out there, had some physicians fill that out, and others I'm sure are their MAs out there. So whatever you're doing, we're glad to have you on board and filling out our surveys when they come out. Wanted to see how experienced people are because it does make a difference if you're kind of new to urology. And nobody new to urology, no less than 1 year. Most of us are been around for a long time. So great. Lots of experience. That's what I was hoping for in this survey. And then where do you practice? That was important because it makes a difference if you're really, I think in a hospital versus an outpatient clinic, you're probably not dealing with stents quite the same way. Although you might. So I wanted to see where people were coming from. And I was guessing that what most people are going to be outpatient clinics, but that's where most of them came from. Then I asked, how often do you encounter patients with ureteral stents in your practice? I think all practices are a little different, so that may vary a bit, but I was not too shocked to find out that most people are dealing with somebody with a stent every day. I think we're from a pretty busy practice, and it's not uncommon to have somebody with a stent every day. So, yep, most at least weekly or some even daily. Very few were monthly, and rare was almost there was nobody who said that. Now, what are the most common reasons that we put ureteral stents in patients? And I let them select all that apply, so it does go up to more than 100%. But we can see by and far, kidney stones are the number one reason people are going to get a stent placed. We know that there are some operations that require stents for surgical healings, and we know that some patients are stuck with these things chronically with tumors that cause obstructions to the ureter. So tumor related, we saw that was seen a fair amount. UTI a little bit, hydronephrosis, and I don't know what the other one was, but So we do see the bulk of this is for kidney stones, and that's kind of what I expected to see on the survey too. Now, what percentage of your patients report discomfort or pain due to ureteral stents? That's why I had no idea, because I know what our own thing is. Um, but that is a big surprise. If you look at it, less than 25% was only 14% of those that responded. So by and far, what 85% of the patients out there are having some degree of pain. And, a fair of them amount are having, quite a bit, reporting quite a bit, 75% at almost 30% of the people who filled this out. So we know stent discomfort is a real thing. One of the reasons, sometimes people might wonder, where do I get the ideas for these episodes, or why do I choose things? So a Euro Patient, my other podcast, which is patient based, I get a lot of feedback from patients in the comments area of YouTube and Facebook. And one of the big areas I recently had was a lot of patients complaining about stents. I mean, I did some kidney stone talks on Patient and got a lot of feedback about stents. I thought, this might be a good subject to look into further. So I did. What are the most frequent complaints from patients regarding these stents? So pain or discomfort, obviously, that was the biggie. Frequent urination, which we kind of know is almost a side effect of the stent for a lot of people. So, but it's pretty common. Blood in the urine, again, a typical side effect of stents. So it's common, but do we tell patients that it could happen? I don't know. And urgency to urinate, that kind of rush, gotta go thing that the stents can also cause. Now, which interventions do you find most effective in managing stent-related discomfort? I said they could select all that applied. So pain relievers like the NSAIDs are used a bit. The antispasmodics, I think the antispasmodics and patient education are probably the two biggest things that we utilize. And I think sometimes we underutilize the patient education. But these antispasmodic drugs, anything that can kind of calm the bladder down, is going to be very helpful. How do you address stent-related infections in your practice? And I just put this one in there because a lot of people associate a lot of those symptoms with infections, and patients will be calling that, I think I got an infection. But we can see that, most people were choosing things like patient monitoring and reactive treatment, checking a urine culture was common. Prophylactic antibiotics, I don't think we don't prescribe them, and it looks like most people don't. So that's kind of a good thing. We don't need to be treating these with antibiotics. Probably not going to help either. Are you familiar with the recent advancements in ureteral stent design? And these are pretty new out there. I don't know if that we've used any of these, or if anybody did out there, put it in the comments. I'd like to know that. But biodegradable stents, coated stents, these are new and exciting things coming out. And by and far, most people are not aware of them. So, hey, there's an opportunity to talk about those. Do you feel there is adequate patient education on ureteral stents in your practice? So I was thought 40% of you said yes, which is good. I'm glad that people are out there educating, but by and far, the no, or some of these other things, better education to patients prior to a stent being inserted, and reiteration upon discharge is needed. Europatient.com educational downloads. Somebody noticed that. Yeah. So there are downloads on my website there for patients. So yes, I think that's one of the areas that's often skipped. And I'll talk a little bit about that in our presentation. So let's get right into it. So the objectives for today are going to be to kind of explain stents a little bit, describe what type of stents are out there, review the procedure for placement and removal, discuss common complications, and highlight patient education and follow-up care. So first of all, what is a ureteral stent? Well, for those of us that are in urology, we're pretty used to this and we know what it is, but there could be some newbies out there. So for you guys, it's a thin, flexible tube. It's put in the ureter and it maintains flow. I always say it's kind of like sticking a straw into the ureter. So it keeps it open and allows urine to flow through it. They have coils or anchors at each end to prevent it from migrating. So it keeps it from going in or out and falling out mostly. And they come in silicone and polyurethane mostly. So here's what they look like. We can see that on the right side, that's a stent. That's what it looks like if it was just sitting there. Has those coils, as I mentioned, on the upper and lower part of the stent. And then on the left side of the picture, we see what it looks like inside the body. So we coil up into the kidney, we coil up into the bladder so that that stent doesn't move up or down and get out of the where it needs to be to help bypass urine. So you can see how that would work to allow urine. It's hollow, so urine can flow right through the tube as well as still around it too. So why do we do these? Well, number one, to relieve obstructions. Anything that blocks the ureter is going to be a reason to have a stent. So things like kidney stones are the big ones and strictures following that. There's a lot of surgeries that require stents afterwards. Anytime we do kidney stone procedures like in the ureter, we go up into the ureter with the scope called the ureteroscope, a little tiny scope in there, and you start banging around inside the ureter. I always say it's like if you ever hit yourself with a hammer and on the finger and you see how it swells up. Ureter does the same thing, only when it swells, it's going to block. So you want to prevent that. So right after the procedure, before the swelling starts, they go ahead and put that stent in place to allow it to heal and the swelling to go down before it's removed. Sometimes where operations are done on the ureters that could require a stent just to keep it open and to help it heal. This is another one you poor ladies sometimes have to go through. You get from pregnancy, the expanding, baby inside of you can push against those ureters. We see it on x-rays where it bows the ureters out, and it can actually cause them to kink off and cause hydronephrosis or backup of urine into the kidneys. So sometimes stents are used to prevent that. And unfortunately, if you have a cancer in the pelvis area that can, compress the ureter, that growing tumor can cause hydronephrosis too, cause blockage of the kidney. So any of those could require a stent to help treat it. So as I mentioned, there's all different types of stents. There's some pictures of how they come in different colors, different materials. There are some open-ended stents where they don't have the coils. The biodegradable is emerging technology. I'll talk about that specifically. And if you're doing pediatrics, they do have specialized stents because they do come in different sizes for different, tall people versus shorter people that you would need bigger, smaller stents. Sometimes choosing the right size stent can make a huge difference in how much discomfort people have. Metallic stents are something that are newer, and we've actually used these in some patients. They're typically used in patients that need a chronic stent in place, like somebody who had cancer that caused compression of the ureter and they need something to keep it open. One of the problems with stents is you can't leave them in forever. They'll block off. And we'll talk a little bit about that in some future slides here. But the metallic stents can be left in much, much longer. And I think as I recall, you can leave them up to a year. Most of them are changed at around 6 months to a year, somewhere in that period of time. And I can tell you, we have used them in patients for long term and have had no issues with them. So they're a great alternative when you have to have a chronic stent in place. Now, how do you perform the procedure? So it's usually done under a general anesthesia, though they say it can be done under a local anesthetic. But it involves going in and visualize. Well, I'm not going to explain it here. Let's go ahead. I got a little show here I'm going to bring up.
So this here is a typical double J ureteral stent. The two curls are called the J curls, and they hold the stent in place. The tube itself is a thin, hollow plastic tube that allows urine in and around the tube to go from your kidney down into your bladder. This tube is then placed over a wire to get in your ureter, and as we remove the wire, you can see that it curls in place. That curl also prevents it from being pulled one way or another so that it stays exactly where it's supposed to go. Here you can see us placing the tube, and it's placed here with the use of a cystoscope so we can visualize the stent being put in the right position. Here it's being placed up, and you can see it's in a straight line, and as we remove the wire, it curls into the right spot. So now it's going to stay in the appropriate position, and it allows urine to go again through and around the tube.
So there you go. That's a pretty simple procedure, pretty quick procedure, usually 10 to 20 minutes as it said in my earlier slide. I thought that was kind of a nice one, really, for those that don't get the chance to work in the OR, get to see how it looks being put in. So what are the complications? That's what kind of kicked all this in. So we said urinary frequency, urgency, and pain are the number one things. They do, even with the coils and stuff, I've seen them migrate out and just get dislodged. And they'll, of course, when they do, they don't work anymore. Biggest one is incrustation. They can get actually blocked from the formation of stones around them. Infections can occur ureteral injury or perforation at the time of placement. When they're putting that little wire, that guide wire in that they push it up over, that can go right through the ureter and perforate it. So those are all things that can commonly happen. Post-procedure care, monitor for those complications. Hematuria, dysuria, we kind of expect it, but we want to know about it. Pain management, as we mentioned, the NSAIDs I think are pretty good medications to try. We try to avoid the opioids. Of course, you don't want patients, that whole crisis thing. Antispasmodics work really good in this particular case, especially the newer ones that don't cause dry mouth. Encourage hydration to prevent them from getting encrusted, and educate. If patients know what to expect, you're going to have a lot less phone calls. Because that's probably one of the biggest things you'll get calls on are patients who had a newly placed stent, and they'll say, saw some blood in my urine, or I'm having a lot of frequent urination. I think I got an infection. So if you educate them beforehand, you may save yourself those phone calls. Patient education. I'm a big proponent for that. I think that you want to let the patients know what to expect and what they should do. Activity restrictions. Now, patients can pretty much do anything they want, but the more active you are with stents, I have noticed patients complain that they'll have more bleeding. So if you're, really in aerobic exercises or doing a lot of heavy working out, you might notice that. That doesn't mean you can't do it, but at least if you expect it, you'll be more tolerable of it. If it's really causing a lot of bleeding, you may need to cut back some of those. Monitor things like fever and severe pain. Those, of course, we want to act on because it could block off. There's risk of infections. Make sure they follow up for their follow-up appointments. These stents are not permanent. Patients have to know number one, know they have it. Some patients don't always know they have a stent in. I've had a few of those cases where patients came in and they were having blood in the urine, and you did an x-ray and there you see a stent. You go, how long have you had that stent? They go, stent? I didn't know I had a stent. So got to make sure you follow up on those. That could be a legal issue. Hydration, plenty of drinking will help cut down the risk of stones. Now, we did mention UroPatient is one of the places to go for patient education, and uropatient.com. You can set, any of you can feel free to utilize all those things that I've placed up there. Throughout my career, I've created a lot of education, and now I've got a place to put it. And I also create videos about it, but ureteral stents you see circled there. Now, I don't make them all myself either. I'm using every resource I can out there. And Suna is a great resource for that, suna.org. And you can go and check out all their patient education handouts. Some of these I've actually been involved in creating. So they're really good. And they had one on ureteral stents, and I just put it on my site. Now, we talked about complications, that patient who came in and didn't realize they had a stent. This is what it looks like. And you can kind of see in the bottom, all encrusted around it, that's calcifications. And up on top, we see it in the kidneys, calcified. That's a real problem when that occurs. So, this patient's got an issue that's going to block off that kidney, and good luck getting that stent out. That's going to be quite a chore. And again, this patient didn't even realize they had one. I can't remember how many years this thing was in. It was crazy. But this is what it looks like. I always say, if anybody's ever, as a kid, did that experiment with sugar and a string to make rock candy, you got that string dangling over highly concentrated sugar. Over time, you'll see crystals form. That's what happens in the urine. There's crystals in our urine. That stent is a nice string, gives it something to grab onto, and that's what it does. We can see all those early incrustations in A and B and see more what that looked like on that x-ray, the one up in the kidney and the one on the bottom that was in the bladder. Now, I got a little video about what happens when you do get an encrusted stent, what has to be done then to get that out. So we can see here that this is a laser like you'd use for kidney stones, and they actually have to go in there and basically chip off all the stone material, just like you're taking out stones. I mean, this is a pretty involved procedure. I mean, rarely do we have to actually go in and operate on an open procedure. Now that we have things like these lasers that can work on stones, we used to in the old days. You can see just kind of going in there and with the laser and clearing all that stone material off until you can grab the stent and pull it out. So it's a real avoidable problem if you get it. You can see sometimes you'll start getting it down and there's still more stone that you got to knock off. So it's gets to be a long procedure. Avoidable too. That's the problem. We could avoid it. So complication management, symptom management, medications for pain and bladder spasms, early removal if there's a lot of problems, especially if we start seeing some incrustation, surgical intervention for severe complications. It happens. It's not common, but can happen. So let's show you what a normal removal of a stent looks like. It's generally done under local anesthesia via cystoscopy, right in the office. There are some patients that have these danglers placed that can actually remove them themselves, or we remove those. The nursing staff typically pulls those out when the patient comes in to have them removed. Usually it's a quick, uncomplicated procedure, but I'll show you what it looks like. In case those of you that may not have seen it. So this is cystoscopy, looking into the bladder. And we can kind of fill the bladder up with some water until we find that stent. And there's the stent, that little curl that's hanging out. And there's a grasper that can go through and grab onto that. We see it coming out the ureter there. Filling up the bladder a little bit with water helps to make it easier to grab it, so you're not having it come up. Whoops, sorry, I hate to hit my mic. A compressed ureter that you're working through. And there we are, visualizing that, and that's the grasper, stent grasper. And we're going ahead and pulling that thing right out, coming out through the urethra, and that's it. Stent's out. Pretty simple to do. Now, one of the things I will mention that as long as I got the moment here, most of the time, I don't know how your practice does it. Our practice, the urologist is scoping the patient, and the nurse is the one who's using the grasper instrument. We do ours with video, which is kind of nice because we can see what we're grabbing. Back in the day when before we had video, I used to have to just go by what the doc said. He'd say, grab and hold. Now, one of the problems that I've had with a lot of my employees that I've taught how to help out with these, and maybe it happened to me once, these instruments are pretty delicate, and you're right away, if you ever help out and they grab it and it falls out of the clip as you're pulling it through, now it's in the urethra. It's harder to pull out of the urethra, and the doc's usually not too happy about having to go back in and grab it. So you really want to grab and hold that strong. Well, if you pull too hard back on that thing that activates the grasper, you can break it. And I've had several employees break them. I broke one. Lesson learned. So you need to hold it. You got to get enough pressure on it so that it stays closed, but don't really go crazy. Don't go zoo on it, or you will break it. And that's just as bad, especially if you don't have a spare grasper. Another hint, keep a spare. So special considerations, of course, pediatric patients need smaller stents. They're and more frequent monitoring. Pregnant patients, again, tailored care to reduce the risk. Long-term stents, you need regular imaging to monitor, make sure that they're not forming stones on these, possibly the use of some of these other stents that I mentioned, like the metallic ones. Now, this is one that a lot of people didn't know about, myself included. Only I'd started reading up on it, which is why I did know a little more about it. But there's these biodegradable stents and some drug-eluting stents that can prevent these formations of stones. So let's talk about these biodegradable stents. What are they? So they're made of a bioresorbable polymer that'll dissolve. And the ones they use are polylactic acid and polyglycolic acid and polycaprolactone, PLA, PGA, and PCL. That's why they use initials. They provide temporary support of the ureters without requiring removal. That's pretty cool. This is an article I found from Allied Materials today, where they were testing a gelatin-based biodegradable ureteral stent, and they actually put it in used pigs to test it. So biodegradable stent was placed in the ureters of a female pig following a normal surgical procedure. The animals remained asymptomatic with normal urine flow, and the stents remained intact for the first 3 days. After 10 days, the ureteral stents were totally degraded. I mean, they just dissolved and no problems. The new formulation combined with a new production process overcomes problems verified with the first generation of natural-based biodegradable stents. So they're coming up with lots of materials that you place it at the time of surgery, it just dissolves, patient never has to have it. As somebody who would be a possible patient, I think that's great. So the advantages: no need for a secondary surgical removal procedure. Reduced risk of incrustation because they're not there that long. Enhanced patient convenience and satisfaction. Potential cost savings. There is a charge to remove a stent, so it's a savings if you don't have to go back in there and another charge. And that patient who didn't know they had a stent, no big deal. Limitations, again, the variable time that they degrade can sometimes lead to a partial blockage. Sometimes if they didn't degrade possibly completely and block the ureter. Not suitable for long-term stent because they're not going to last. Higher initial cost because, of course, anything new is going to be more expensive. And there's a lot of ongoing trials, so it's a limited availability. You may not have seen any of these before this talk. Indications for use, again, as we said, for short term, like post-stone, ideal. So the future direction is to develop more predictable materials. These drug-eluting capabilities, such as antibiotics, could be given off by the stent. They can be coated with an antibiotic resistance things. So kind of some new territory to look at. We'll certainly, as these things come out, I'll try to get companies that are involved in it to talk about what they are and how they work. So at the end of our talk now, key takeaways. So stents are absolutely vital for managing stone and anything that can block the ureters. We do need to be aware how we're managing these, taking sure with the patients that they're aware of everything that's going on, that they have a stent. Those are really important things. And proper education and follow-up is huge. You have to have that. So with that, I'm going to go ahead and bring Lori on here. And if you have any questions from the audience or comments, Lori will be glad to read those off. So Lori, any comments coming through? Lori, you're muted. See, Lori hasn't been on in a few weeks.
I'm out of practice. No comments coming through. Great talk. I was kind of excited about this one because we actually have a meeting on Monday morning with our team about how to get less people going to the emergency room. And one of the big ones is stents.
Yeah.
Because they're not educated. And so the education, while they have the stent is so important, but also after the stent is taken out, because even after the stent is taken out, and I'm the lucky one who had this experience because I had a stent. I had a dangler stent. I pulled mine out in it didn't happen for me right away, but later on that day after I pulled it out, my ureter spasmed, and it is like having a stone again. And it is horrible. And I didn't even know, and I was already a urology nurse, and I didn't even know that can happen. And I'm on the phone crying with the on-call doc and and I ended up going back to the emergency room because of the pain. But the thing that helped me the most through that was not so much pain medication or anything like that, but it was actually just sitting in a hot bath. Like it was just, just relaxed and calmed. And so there's ways that you can keep people out of the ER while they have a stent or after they have the stent removed, because we just want to avoid that, especially how busy our ERs are right now. So,
oh, absolutely,
that was great.
Yeah, and it's no fun to be sitting around in the ER in terrible pain either, because they're not going to get to you right away. That's not, their list of things are, heart attack, strokes, things, they're going to get way above kidney stone pain. But it's to you, it's of course it's number one. But yeah, that was one thing I forgot to mention is people can get spasms of the ureter. It's not a blockage where you have to go back in usually and reinsert a stent, but it's just it goes into spasm and blocks itself. Unfortunately, you had to experience.
Yeah, people will think that they oh yeah. Well, it was a learning experience, I'll tell you. But a lot of people will call us and think that, oh, the doctor didn't get the stone. I don't believe he got the stone. I'm having so much pain. And it's not. It's the spasms or the stent itself. So yeah, a lot of people, the education is so important to, like Vic said, to reduce those triage calls, because I can tell you there is a lot of our calls are due to stent pain. And if they're
Yeah.
not educated beforehand, or if they are educated beforehand, you get so many less calls.
Yeah, that's a good point. For those of you that are out there in the audience that are watching the show, feel free to put a comment through and let me know about your own experiences. Have you had anything that you found with stents that I didn't talk about, or any questions about stents? I'd be glad to hear those. That's what we're all stents all day today. No, not all day, just for this
We
episode.
do
But
have some comments that came in.
all right,
So
good.
we had a comment from Diane. I don't know why it's not showing up, Vic, but she said, great review with common sense info. Thanks. And Rajesh
Here, I'll
said,
bring it
very
up
good
here.
information. Oh, there you go. And then
You
he
forgot
said,
how to
very
click
good
them, huh,
information
Lori?
about. No, I clicked it. It's not
It wasn't showing.
doing anything for me. No.
Huh. All righty. So yeah, I think that, the education part is huge. You know, have you had a lot of experience with patients calling about blood in the urine post stent? That's been one of the phone calls that we get a
Absolutely.
lot. It's just, they just don't know. If they expect it, I think they're not going to call. But that's
You know
one of
that
those red
and
flags
this
for,
applies to anybody who has blood in the urine. Whenever patients say they have blood in the urine, I'm like, that is your sign to take a step back and rest.
yeah.
You're likely doing too much. Drink a lot of water and rest, and
Yep.
they do fine.
The metallic stent, have you guys used that in your practice
We have,
for
yeah,
long
and we
term?
have had people, yeah, and a lot of it is definitely for those patients who have, unfortunately, tumors or what have
Yeah.
you, and they're going to have it long term. So we have used those. We've also had the patients that come in that didn't realize they had a stent, had the incrustations, and yeah, we've had a lot. We've had to follow. It's important to follow these people, because a lot of practices, I know ours in the beginning, did not track these people, and now we're tracking because of the liability.
Yeah.
A lot of people, they just, they're after surgery, they're not listening to what you're saying all the time, and you tell them that they have to come back for a stent removal, and they don't, and then they show up in your office a year or two later with an infection, and yeah, and then to see that they still have a stent. So
Yeah, yeah. No, you need to have a protocol. We actually had you'd put a card in a stent reminder card that was at our thing to look at to see who hadn't come in to have it removed, so you could follow up with them by phone. Now I think the computers probably can do that a lot easier than we can, but you definitely need some kind of protocol in place, because that could be definitely a lawsuit if your patient doesn't follow up and you don't try to make an attempt to reach them. You put the stent in, you're responsible for it.
right.
And out there, as
I
you'd be
have
curious if
there's
anybody. Mhm. Go ahead.
Oh, we do have, let's see. We have oh, I can't click on it, Vic. Sorry,
So
it's not
I'll bring
working.
it up.
There
We'll
you
have to
go.
look into that.
So Wendong Zhang said, do you ever use trial of steroids to help patients with terrible related pain? We have, we have not. We usually just do the ibuprofen and so forth, but we have not used steroids.
Yeah, I think they're thinking probably the swelling. We never used it, so I don't know. I would have to ask uh, Wendong if they've used it and how successful it was, because it's a good thought, but I don't know. It's definitely, as you said, the antispasmodics seem to be one of the number ones that we use. Do you use any of this stuff that turns the urine orange? What's it?
We do. Pyridium.
Peridium,
Yeah,
yeah.
or
Thanks.
azo. A lot of insurances don't cover pyridium anymore in the pharmacy, and so we tell them just to get the over-the-counter azo.
Yeah. So again, a lot of
That
times
seems to help them.
yep,
Yeah.
that'll do the trick.
There's another important thing that we do. I don't know if anybody in the audience, their practices do, but we do require, before we take this stent out, we do require a urinalysis at least to make sure that it doesn't look like they have any blatant infection.
Yeah, that's
Because
a
if
good
they
point.
do, we do not remove the stent. They can get really sick. So
Yeah. Yeah, you don't want to be instrumenting patients with an active infection. So definitely check a
right.
UA before you do anything, and culture and treat before
And the
you take
UAs
it
are
out.
going to look messy. Yeah, anybody with a stent, their urine's going to look horrible. But if they have positive nitrites and things like that, and they're not on azo or pyridium, which can cause that, if they're
Yep.
asymptomatic, they may, but if they're having, a lot of symptoms, fever, things like that, we would never take it out. So
Yeah. So a
I
good
think
point.
you
So
have a high from Puerto Rico.
wow. It must be nice to be where it's nice and warm.
Yeah,
We're-
right.
Lori and I are up in the Chicagoland area, and we're going to be
Ugh.
facing that polar vortex that's supposed to hit. So yeah.
It's horrible. So, Vic, I have a question for you in the audience to see if anybody has seen this before. We started doing this in the office recently for percutaneous lithotomies, where they go through the back to take the stone out and they place the stent. We have a physician that's actually putting dangler stents where the string is actually coming out through their back. Yeah.
Oh, out through the back.
And then we
Wow.
pull it with a string through the back. And the first time I did it, which was pretty recent, it's not easy. You have to pull, like the first time I was like, it's not coming out. There's no way I can pull this out. And so the doctor comes in with me and he's like, you just have to pull it a lot harder. And it's kind of scary. You don't want to, but I was just curious to see if anybody else had that experience. It was new for me.
Let me make sure I understand this. So they have a stent. They don't have a nephrostomy tube coming out, do they?
No.
So it's a sealed.
So it's literally just the string coming out of their back.
Huh.
And then you pull it through that. Yeah, it's
cool.
really interesting.
You'll have to send me that physician's information. Maybe they would come on and talk about that procedure.
Yeah, absolutely.
That really sounds interesting. To, save the patient the trouble of going through a urethral procedure.
Right. And to be quite honest, the few that I've done, they don't feel it as much as the actual dangler stent pulling it through from the urethra.
Yeah.
It's
we've had several patients in my career with nephrostomy tubes that we've removed, nursing staff removes, and they never seem to complain about it. So it's an interesting concept. So
yeah,
cool. Yeah, they'll be send me an email with that patient, that doctor's email.
Yeah,
and
I sure will.
Go ahead and hit them up for it. That's a lot of the ways I try to find, programming is just something that we're curious about, because there's a lot of stuff out there. I was just reading an article recently about some new terminology for BPH procedures, and the guy who authored it, I figured, well, what the heck? I'll send him a letter and an email and see if they're willing to talk. And he's going to be on the show in March, so it's just
great
way to find new and interesting things for the show. So, all righty. Sure. Well, I don't see any other questions. I got a few more things I'm going to take care of, some information about next week. So, as you noticed, I was showing that removal of the stent that was kind of with a cystoscope. The scope that was used for that one is a disposable. There's a company by the name of Ambu who makes these. And I finally got them to agree to come onto the show to talk about the advantages. And so
this week on UroNurse, we're excited to host Kate Bouton, market manager for Ambu, as she presents Maximize Efficiency with Ambu's single-use cystoscope. Kate dives into how this cutting-edge device is revolutionizing urology practice by enhancing patient safety and streamlining clinical workflows. Learn about the innovative design, cost efficiency, and the elimination of cross-contamination risks that make the single-use cystoscope a game-changer for healthcare providers. Tune in to discover how your practice can benefit from adopting this groundbreaking technology and gain valuable insights from an industry leader in medical innovation. Join us next Saturday at UroNurse.com.
So yeah, join us next Saturday to learn more about that scope, and hopefully it be some if you're not using it in your practice, give you some ideas of what there are, some possibilities out there. And I'm curious to learn more about it myself. So we do have some of those in our office, but I thought it'd be worth learning more about the scope anyway. So also, just to keep everything, whoops, I got to get my full view in here. For those of you that are checking out UroPatient this at 10:30, just following this show, I'm going to be talking about your urology appointment doesn't have to be awkward. Watch this first. So I got a number of patients that had written in, especially male patients, about how uncomfortable they were at coming in to see females in the office. If it was a female doctor, if the nurse was the female nurse doing it, I thought, maybe this is time to address that. So check it out on UroPatient, see what I had to say about it. So that'll be following this show at 10:30 live. Also, if you haven't caught Dr. Jeff Albaugh's new podcast that we're doing together, January 21st, this Tuesday, is our third episode. He's going to be talking about men's sexual health, breaking myths and building confidence. It's on every Tuesday at 7 p.m. Central Time. Jeff is doing a great job of lining up a lot of talent to talk about everything you ever wanted to know about sex. So be sure to join us for that. And that's about all I have to say. Lori, any final thoughts?
No, I think it was a great show. And remember, education is key for these stents. Educate your patients.
Yeah, if you learn nothing after this show, is learn to get patients educated, because you'll save yourself a lot of trouble. I always find that a patient who knows what they're getting into is going to be a much more cooperative, better patient to deal with, and save you a lot of phone calls. And it's nice to have a phone call, but at the end of the day, I don't know about you, 20 calls, with problems that 10 of them you didn't have to probably address is kind of a bit much. So all right. Well, we'll see everybody next week on UroNurse.